Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be going over osteoporosis. Now, before we get started, as always, I'm going to ask you to please help support this channel so I can push out more videos and content for you. Please like this video if you haven't done so already. You know you're going to love it. Subscribe to this channel. And don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. All right, so let's talk about metabolic bone disorders. We're going to talk about osteoporosis. Now, let's start with this term that you need to know right here, osteopenia. Osteopenia, osteo, bone, penia, little bit of. Guys, sometimes you may not know what the word means, but if you break it down, it'll make sense to you. So osteopenia, this is a low bone mineral density. The consequence of having osteoporosis, by the way, look at this word, osteoporosis, osteobone porosis, porous bones. Just hearing that, what does that mean to you? Weak bones, right? Patient's going to be high risk for fractures. The consequence of osteoporosis is bone fractures. That bone is weak. It is projected that one of every two look at this, Caucasian women, that's a risk factor for osteoporosis. Just being Caucasian, a Caucasian woman is a risk factor for osteoporosis. One in every two Caucasian women and one in every 5 men will have osteoporosis-related fracture at some point in their lives. Let's talk about prevention. Give me 1 second, guys. Okay, guys, I'm back. So let's go to prevention. What are you going to teach your patients on how to prevent osteoporosis? So primary osteoporosis occurs in women after menopause. So let me stop right there. Well, let me keep going. After menopause and men later in life, but it's not merely a consequence of aging. This is important for you to know. You guys have to understand this. The reason that we see osteoporosis in women after menopause, estrogen, that's the key. So estrogen is one of those hormones that just prevents the calcium from leaving the bone and going to hang out in the blood, right? Estrogen is what was keeping all of the calcium in the bone where it was supposed to be to make the bone strong. Once the woman goes through menopause and her estrogen levels are severely decreased, guess what? The calcium that is supposed to be in the bones, that's supposed to make the bones strong, says, woo, party time, no more estrogen. We are out of here. They leave the bones and go to the bloodstream and the bones get porous. So that is very important for you to know. Women after menopause, after that estrogen level has decreased severely, that puts them at risk for menopause, and men later in life. You want to know why? Of course you do. I'm going to tell you why. Just like for women, estrogen was what was keeping calcium in the bones. Estrogen is for women what testosterone is for men. And so as men get older, their testosterone levels tend to decrease, and that puts them at risk for osteoporosis as well. All right, let's keep going. Failure to develop optimal peak bone mass and low vitamin D levels contribute to the development of osteopenia without associated bone loss. Let's talk about that. Why is this important for us to understand? Well, guys, in order for you to absorb calcium, you have to have vitamin D. Vitamin D is what helps you. There we are. Vitamin D is what helps you to absorb calcium. So that's important. Early identification of at-risk teenager and young adults, increased calcium vitamin E take, participation in regular weight-bearing activities, modification lifestyle such as reduced use of cigarette, caffeine, carbonated drinks, alcohol are all interventions that will decrease the risk of fractures later in life. You need to know all of them. Okay, and I'm going to talk about this again, but you know, if this is something you're studying for a test, trust and believe you're going to see this on that exam, and most likely it's going to be a select all that applies. Don't say I didn't warn you. What did I write over here on the side? I wrote something. I wrote older Asian women something. Oh, okay. Okay, so I'll talk to you guys about this as well. Other risk factors for osteoporosis, excuse me, besides being Caucasian, if you're an Asian woman, if you're an older woman, If you're a woman taking hormone replacement, that places you at risk, and we'll talk more about that. But I put that on the side. I guess I got too excited. I couldn't wait for it to come up in the book, but I know it has to be somewhere in this book. But that you need to know for testing purposes. They ask about it a lot, okay? Secondary osteoporosis is a result of medications or diseases that affect bone metabolism. There are certain medications that can cause your bones to become porous. A famous one is corticosteroids, right? We know that corticosteroids, yes, they decrease inflammation, but anytime a patient's taking a corticosteroid, you have to be worried about hyperglycemia, you have to be worried about, infection, and you have to be worried about osteoporosis because they tend to make the bones very porous, right? And an honorable mention when it comes to I can't speak. When it comes to corticosteroids are ulcers. They tend to give you gastric ulcers as well. But anyway, this is saying that, you have primary osteoporosis, which I just talked about, and secondary. The secondary osteoporosis comes from either a medication or a disease that causes the bone to be porous and affects the bone metabolism. So now let's look at these risk factors that I promised to go over. Let's talk about them in detail. And guys, you can't run away from this because you're going to see this for testing purposes. You're going to see it for RN. But if you decide to keep going for your degree and you want to be an NP, you're going to see this again. You can't run away from it. So just know it now. All right, let's talk about these risk factors. First of all, genetics. Caucasian or Asian, that places you at higher risk for osteoporosis. Being a woman, especially after menopause, of course, having a family history or having a very small frame. These predispose you for having low bone mass. What about age? Postmenopausal, and usually postmenopausal women are older, right? Having advanced age, low testosterone in men. I don't know why I didn't put a star next to that. Estrogen is to women what testosterone is to men. So for men, that testosterone is what helps keep the calcium in the bone and keeps it strong. And decreased calcitonin. Remember calcitonin, guys? What gland's responsible for calcitonin? The thyroid gland. So not having enough calcitonin, that can cause the calcium to leave that bone and go to the blood. Look, all of these hormones, estrogen, calcitonin, testosterone, they inhibit bone loss. Next, let's talk about nutrition. Calcium is what makes the bone strong. So low calcium intake, that makes sense. Low vitamin D intake. Guess what? You can take as much calcium as you want. If you don't have vitamin D to absorb the calcium, what's the point? High phosphate intake. Guys, phosphate has an inverse relationship. Sorry, I have to have my coffee. With calcitonin. Okay? This reduces nutrients needed for bone remodeling. So low vitamin D, low calcium, and high phosphate. High phosphate can cause that calcium to leave the bone and go into the blood. Physical exercise, this is important. If the patient's not a couch potato, they're not moving around, that can cause that bone to become porous. Sedentary lifestyle, that's another way of saying couch potato. Lack of weight-bearing activity. I need to put a star next to this because they usually ask that in a test question. Those weight-bearing activities such as walking, right? That forces the calcium that was hanging out in the blood where it wasn't supposed to be to go back into the bone to make the bone stronger. So if the patient's not doing much weight-bearing exercises, that can put them at risk for osteoporosis. Or if they're doing low, or if they have low weight and body mass index. Remember, that smaller frame alone places them at risk for osteoporosis. So all of these guys, the bones need stress for bone maintenance. When you're doing those weight-bearing exercises, or you're heavier, so that's more weight on the bones. Remember, your body's meant to survive no matter what, right? So Your bones are saying, whoa, we got stress. We need to be stronger. We need calcium. Calcium. I know you're hanging out in the blood, but I need you to come back over here where we are in the bones to make us stronger. If you think about it that way, you'll never forget. Lifestyle choices. Coffee, what I love to drink. Alcohol, smoking, lack of exposure to sunlight. Why lack of exposure to sunlight? What are they really getting to here? Vitamin D, that's what they're talking about. All of this reduces osteogenesis and bone remodeling. And last, medications. Certain medications can cause you to be at risk for osteoporosis. Number one on that list, baby, corticosteroids. When you think of corticosteroids, I need you to think of stomach ulcers, infection, hyperglycemia, and osteoporosis. Those 4 things. Corticosteroids, anti-epileptic medications, heparin, thyroid hormones. And there's certain diseases that can cause this as well. Anorexia nervosa. If you're not eating food, you're not eating things that have calcium in it. That makes sense. Hyperthyroidism. What was the gland that earlier I just told you was responsible for calcitonin? The thyroid gland. That makes sense. Malabsorption syndrome. So you may be getting that calcium, but you're not absorbing it the way you're supposed to. Kidney failure. So make sure, let me put a star next to kidney failure because that's a big one too. They tend to ask about that one a lot as well. So make sure you guys know that. Let's move on to the pathophysiology. Osteoporosis is characterized by reduced bone mass, deterioration of bone matrix, and diminished bone architectural strength. Calcitonin. Remember, I talked to you about calcitonin. You guys don't forget the thyroid gland is responsible for calcitonin. Calcitonin, which inhibits, it stops bone resorption and it promotes bone formation in osteoporosis is decreased. Estrogen, which inhibits bone breakdown, also decreases with aging. But on the other hand, parathyroid hormone increases with aging, reducing bone turnover and resorption. The consequences of these changes is net loss bone mass over time. Let's not skip over this because I got to make sure you understand everything they're saying in this paragraph because it's a lot. So give me a second. Let me underline the most important things. Okay. Those 3 that I just underlined, those are the most important things you need to get out of this paragraph. Calcitonin, which is supposed to promote bone formation, is decreased, which means the bones are going to get what? Weaker. Estrogen, which is supposed to keep the calcium in the bones and not go try to party in the bloodstream, right? If it's decreased, the bone gets weaker. And last, parathyroid hormone. When you guys are thinking, just like I said, the thyroid is responsible for calcitonin. The parathyroids, this is your parathyroid hormone. Look what parathyroid hormone does. It increases bone, with aging, I can't speak. With aging, increases bone turnover and resorption. When you think of the parathyroid hormone, what it's supposed to do is increase calcium in the bone. I'm sorry, guys. In the blood. Parathyroid hormone is supposed to increase calcium levels in the blood. Well, that's a problem because part of osteoporosis is having weak bones. If all of the calcium is in the blood, what about the bone? The bones get weak because we want it in the bones, making the bones strong. Now, the reason I don't want you to think that parathyroid hormone is a bad thing. It's not, because sometimes the patient may have way too much calcium in the bone. And some of that calcium needs to leave the bone and go into the blood. So in that situation, the parathyroid hormone is a great thing because it will force the extra calcium that was in the bone to go to the blood. So there won't be too much in the bone. However, it can be a bad thing. Imagine the patient has just enough calcium in the bone, but here goes parathyroid hormone activating and causing the calcium to leave the bone, go to the bloodstream. So you need to understand what those 3 do. and why it's important when we're talking about osteoporosis. Look, the withdrawal of estrogens. Remember, estrogen is what keeps the calcium from leaving the bone. The withdrawal of estrogen at menopause or with an oophorectomy causes an accelerated bone resorption within the first 5 years after cessation of menses. It's basically like a free-for-all for the calcium. They're not stuck in the bone anymore, and they leave to go party in the bloodstream. Risk factors, how many times have we seen this? Small framed, Asian, Caucasian women are at greatest risk for osteoporosis. A diet that risk factor. A diet that includes adequate calories and nutrients are needed to maintain bone, calcium, and vitamin D. Patients who had bariatric surgery are at increased risk for osteoporosis as the duodenum is bypassed. Why is that a problem? Why do we care that if the person had gastric bypass surgery, that now the duodenum's bypassed? Why do we care about that? Look at what it says. This is the primary site for absorption of calcium. So if they had a gastric bypass and the part of their body that is supposed to absorb that calcium has been removed, don't you think that's going to put them at risk for osteoporosis? Of course it is. Patients who've had GI disease can cause patients who have gastrointestinal diseases that cause a malabsorption, and they're giving examples such as celiac disease or alcoholism. Those kind of disorders may benefit from additional magnesium supplements. Why? Magnesium helps with that absorption of the calcium. That's why. Resistance and impact exercises are beneficial in development and maintaining bone mass. Why? The bones need to feel stress. They need to feel that pressure to force the calcium that was hanging out in the bloodstream to come on back to the bone and make them stronger. Obesity's been recently recognized as a risk factor. Immobility contributes to the development of osteoporosis. Being a couch potato, most overweight individuals are less active, so it makes sense. They're less active and they may not consume key nutrients that have, calcium in it. And that puts them at risk for bone demineralization. Assessment and diagnostic tests. Osteoporosis is diagnosed by the DEXA scan. Okay. That DEXA scan, it provides information about the patient's bone mineral density. That's your key, the DEXA scan. You guys know I have a speech impediment. I've always had it. And during times of stress, it gets worse. I'm really stressed this week, so please forgive me and be patient with me. Baseline DEXA testing is recommended for all women older than 65, right? Because by that time, they should have gone through menopause. For postmenopausal women older than 50 years with osteoporosis risk factors, and for all people who've had a fracture thought to occur as a consequence of osteoporosis. So if any woman, if you're older than 65, you should have a DEXA scan. If you're not older than 65, but you're menopausal, 50 or older, you should still have it. Or anyone that has had a fracture and is thought to have the fracture because you have osteoporosis, you should have a DEXA scan, because remember, that DEXA scan is the key. That's what's going to diagnose osteoporosis and tell you what that bone mineral density is. Medical management. A diet rich in calcium and vitamin D, because remember, the vitamin D is needed to absorb the calcium. Such a diet, this includes skim vitamin D enriched milk or other foods high in calcium. They're giving you examples. What did I teach you guys? When you see examples in parentheses, they tend to show up as like all that applies on exams, right? Yes. Cheese, other dairy products, steamed broccoli, canned salmon with bones. A cup of milk or calcium fortified orange juice contains 300 milligrams of calcium. The recommended adequate intake level of calcium for adults is 1,000 to 1,300 milligrams daily. What else? Weight-bearing exercises. Remember, the weight-bearing exercises forces the calcium that was hanging out in the bloodstream to go back to the bones to make the bones stronger. Recommendations include 20-30 minutes of aerobic bone stressing exercises, not swimming, bone stressing exercises. Weight training stimulates an increase in bone mineral density. In addition, exercise improves balance to help you not fall and break something, reduces incidence of falls and fractures. Pharmacological therapies. Let's talk about medications. The first line, whenever you see first line, pay attention. Ding, 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 ding. The first line medications used to treat and prevent osteoporosis include, well, duh, calcium and vitamin D supplements, right? Calcium and vitamin D supplements and biophosphonates. To ensure adequate calcium intake, a calcium supplement such as Caltrate or this drug, this med, I'm not going to try to pronounce it, with vitamin D, because vitamin D is needed to be absorbed, may be prescribed and taken with meals or with a beverage high in vitamin C to promote the absorption. The recommended daily dose should be split and not taken as a single dose. Common side effects of the calcium supplements are abdominal distension and constipation. Calcium from foods is better absorbed, but the calcium supplements can do the job if necessary, if maybe the patient's lactose intolerant. Let's talk about biophosphates, because besides the calcium and vitamin D, biophosphates are the first line drugs used for osteoporosis. Biophosphates then include daily or weekly oil preparations of, and the ones that show up the most for testing. So if you're going to know any of them, know this biophosphate is the alendronate, which is a Fosamax, and this one, the rizendronate. This one, I'm not going to try to pronounce it. I did try. I sucked. This one, the Actonel. These are two drugs that tend to appear the most for testing exams, but I've seen Boniva once or twice, but just make sure you know them. These biophosphate, there's some important things you guys have to know about the biophosphate. They increase the bone mass and they decrease the bone loss by stopping osteoclast formation. Osteoclast, osteo, bone, clast, to break down. So not only does it increase the mass of the bone, it stops that bone from breaking down. Wonderful drug, but there's some important things you guys got to know about the biophosphonates. And I don't see them here. Oh, yes, they are. I see them here. Let's go down here and then I'll come back here. So patients who are taking biophosphonates, they need to take the medications. Look at this, on an empty stomach. NCLEX expects you to know this. You better know this. In the morning, on an empty stomach with a full glass of water. And let me tell you something, biophosphonates are so hard. They are so hard on that mucosal lining. That patient needs to sit up. They can't lie down. They must stay sitting up or standing up for 30 to 60 minutes after administration, so it doesn't creep back up the esophagus. Patients on biophosphonates may develop, look at this, esophageal or gastric ulcers. Yeah, they are very, very, very hard on the mucosal lining. You need to know that. They need to take it in the morning on an empty stomach with a full glass of water, and they have to sit up or stand up for at least 30, 60 minutes afterwards. Adequate calcium and vitamin D intake is needed for maximum effect, but the supplements should not be taken at the same time as biophosphonates. And we know this because nothing should be taken at the same time as biophosphonates. Side effects of biophosphonates include, again, the GI symptoms: nausea, flatulence, diarrhea, constipation, dyspepsia. One more thing I want to cover with you guys. This is an important chart. Can you see this? Let me make it bigger for you. All right. So this is teaching you're going to do for the patients. For adolescents and young adults, you're going to teach them the risk factors of osteoporosis. You're going to teach them how to identify foods that are high in calcium and vitamin D, which I've already gone over this video. You're going to teach them consume diet with adequate calcium. Remember, 1,000 to 1,300 milligrams per day, and vitamin D. That vitamin D is needed for absorption of the calcium. Teach them to engage in weight-bearing exercises. Is swimming a weight-bearing exercise? No. It's a great exercise for someone with something like asthma, but not osteoporosis. You're going to teach them lifestyle modifications. Stop smoking. Avoid smoking, alcohol, caffeine, and carbonated beverages. For the menopausal and postmenopausal women, in addition to everything I just talked about, in addition to that, you're going to teach them about taking calcium supplements, reducing the risk of falls. Make sure they have good lighting. Make sure there's nothing, no clutter on the floor. Make sure there aren't any cords just hanging around. Make sure that the floors are like even, things like that. Fall precautions, right? Teach them good body mechanics. Assess the home for hazards contributing to falls. For men, in addition to everything I just mentioned, in addition to that, you're going to list the risk factors associated with osteoporosis in men, including medications. Professor D, do I have to know those medications? Yes, you do. There's a reason the author listed this. I think this is the second time we're seeing this medication. They're not repeating themselves just for the heck of it. You need to know it. Corticosteroids, anti-seizure medications, aluminum-containing antacids. Teach them about chronic diseases that can cause osteoporosis. Again, kidney disease, lung, GI diseases, and undiagnosed low testosterone levels, because low testosterone can cause their bones to become porous. Teach them about the importance of participating in screening for osteoporosis. By the way, I've seen this a couple times. Screening for osteoporosis, you need to know that this is a secondary prevention measure. You know how you have primary prevention, secondary, tertiary? Osteoporosis screening, that's a secondary prevention measure. You need to know that. And teach them to talk to their healthcare provider about medications such as alendronate. This is a biophosphate to enhance the bone mass and to correct the testosterone deficiency if their testosterone is low, and that's what's causing the patient to have osteoporosis. And guys, that is osteoporosis. That's osteoporosis in a nutshell. Let me know what you guys thought about this video. I promise, guys, I'm reading your comments. I just can't reply to everyone, but I'm reading them, and I have an ever-growing list of videos that you guys either want me to make or you want me to go more in detail about, and I'm doing it for you. So let me know in the comment section what you'd like to see me cover, or what you'd like to see me go more in detail about. Or maybe you don't want me to see me do a lesson. Maybe you want me to do a video like the ones that are published on Sundays, the one where I actually go over questions. If you want me to do one of those videos, just let me know in the comment section. Please don't forget to like and subscribe. And don't forget, I have audio lessons available on my website at nexusnursinginstitute.com. Guys, thank you for watching this video, and you guys can catch me on the next video.